I'm Dr. Saundra Stock. I'm a professor here at the University of South Florida, and I'm a child psychiatrist. And I'm going to be talking to you about disruptive mood dysregulation disorder, background, pharmacologic, and non-pharmacological treatment options. Okay? Obviously, to list the criteria for disruptive mood dysregulation disorder, if you don't happen to know those already, to describe the approach to treating DMDD, including prioritizing interventions, and discuss potential treatment options for it. So I have no financial disclosures, but certainly all medications that are going to be talked about today are not FDA approved, as nothing is FDA approved currently for a treatment of DMDD. So what is DMDD? In case you aren't familiar with the criteria, DMDD is severe recurrent temper outbursts that are out of proportion in intensity or duration to the stressor. They are inconsistent with the developmental level. They occur 3 or more times per week. With that, the child has a persistently irritable mood most days, nearly every day. This needs to be present for at least 12 months, so it needs to be a chronic condition. It needs to be, there needs to be no more than 3 months without symptoms. The symptoms should occur in multiple settings, at least 2 out of 3 settings. And children should be at least age 6 to diagnose this, because before age 6, temper outbursts and temper tantrums are much more common for that developmental level. So children should be at least 6 when they get the diagnosis, and the onset of this diagnosis should be before age 10. Children should never have met criteria for a manic episode, when these symptoms should not be exclusively occurring during a depressed episode. So the DSM-5 says that if the child has DMDD, if they have the presence of oppositional defiant disorder symptoms, that disruptive mood dysregulation disorder should be diagnosed, and not ODD, that basically disruptive mood dysregulation disorder kind of trumps the diagnosis of ODD. So kind of the background for DMDD, where did this come from? Certainly we know that a chronic irritable mood is significantly impairing, but not very diagnostically specific. We've known for a long time that children who have ADHD plus mood instability have a worse prognosis than children that just have ADHD. We know that irritability is listed, irritability is listed as a specific criteria for a manic episode, and focus on irritability led a lot of children to be diagnosed with bipolar disorder, kind of focusing on that irritable symptom. And with that, people were ignoring the requirement for periodicity or discrete episodes of irritability when they were looking at children who have kind of chronic irritability. That increase in bipolar disorder diagnosis led to a huge increase in antipsychotic prescribing for children, and created a lot of negative press for child psychiatrists and physicians treating children, and got a lot of researchers and people looking at, was this the correct diagnosis for kids? Is there a different diagnosis that better captures irritability? What are some different treatment options? With that, NIH started looking at this. Ellen Liebenluft, who's not a child psychiatrist, but she's at NIH, and she started looking at children with chronic irritability, and she came up with criteria that was called severe mood dysregulation, or SMD is what it gets referred to as in the literature. And you'll see a number of studies with that, because they kind of put together that criteria in 2003. Criteria for SMD included an abnormal mood for at least half of the day on most days, noticeable by other people, a marked negative reactivity to neutral stimuli, with outbursts occurring at least 3 times per week. And they had hyperarousal symptoms, including insomnia, restlessness, distractibility, racing thoughts, pressured speech, or intrusive speech. So the criteria for SMD basically morphed into DMDD and DSM-5, dropping, though, the hyperarousal criteria that are part of SMD. So as we look at the literature, we're going to be looking a lot at SMD, studies with children that meet criteria for SMD, to try to figure out what we might be able to do. So if we just think about a differential diagnosis of explosive outbursts, clearly if a child rarely has explosive outbursts, we wouldn't think they have DMD or bipolar disorder. If they have frequent outbursts, we would look and see, are these a change from their previous self? Is this change from their previous behavior? If it's changed from their previous behavior, and it's a child, we would first want to rule out stressors, looking at school-based stressors. Do they have a learning problem? Are they getting bullied? Do they have stressors at home? Is there family dysfunction, family problems, or perhaps abuse occurring at home? If it's a teenager who is significantly different than their usual self, we'd want to look at, is there any drug use? Is there depression? Is there anxiety, or more rare, are there manic symptoms, or are there psychosis? So clearly, if it's a change, we would look at those things. If the explosive outbursts are chronic, and then we want to look at kind of what's their mood in between these outbursts. If they seem fine until they are frustrated by something, that is more likely ADHD plus oppositional defiant disorder. And certainly we see lots of kids and families lots of kids that meet that kind of definition, lots of families that tell us the kid is fine if you let them do what they want all day long. It's only when they're given limits or requests are made that they have an outburst. Other kids are irritable all the time. They seem persistently negative, react negatively to neutral stimuli in the environment. Even doing things by themselves, they seem somewhat negative. And in those kids, we might be thinking that they might have Disruptive Mood Dysregulation Disorder, or DMDD. So how common is this? Well, we don't really know for sure. There's just been some limited trials looking at this. When people have looked back at large cohorts of kids that have been studied in the past, looking at things like the Great Smoky Mountain cohort of children, or the Caring for Children cohort, or other groups of children, we see in the Duke preschool anxiety study, they showed that 17.7% of preschoolers were described as having frequent tantrums. If we look at a couple of other studies put together, 9% of 6 to 12-year-olds were described as having irritability and tantrums. 6 to 7% of early adolescents had frequent severe tantrums. And in the National Comorbidity Study of Adolescents, they saw that 5.6% of adolescents had irritability and tantrums. So certainly irritability and tantrums are common. When you really get down to, is it happening in 2 out of 3 settings? Is it happening for at least 12 months? And looking at all of the criteria, the rates of DMDD were much lower. It was more like 2 to 3% of preschool children, which technically you can't diagnose it in preschool children, but looking at those cohorts, 2 to 3% of kids would have met criteria if they had been 6 or older. Looking at the kids older than 6, about 1 to 3% of 9 to 12-year-olds meet criteria, and somewhere between 0.12 to 0.8% of adolescents. If you look at comorbidity, basically DMDD very rarely occurs alone. There's a difference with more comorbidity in the clinic samples as compared to community samples, but certainly we see that in clinic samples, the kids that we're going to see in clinic, a lot of them have oppositional defiant disorder, a lot of them have ADHD, a lot of them have 75 to 80% to 85% will have ADHD and ODD, or anxiety and depression. And when you look back at the severe mood dysregulation study they were doing at NIH, 75 to 85% of those kids had ADHD plus ODD. They met criteria for that. So certainly we see that these kids have a lot of other conditions. What happens to it over time? What's the course of it? Looking at that NIH cohort with 200 kids that had severe mood dysregulation, looking at them at 2 years, 48% still met criteria for SMD. At 4 years, 39% still met criteria for SMD. When they looked at when the DMDD criteria came out, they looked at their SMD cohort and found that 194 of those kids also met criteria for DMDD. And when they looked at those kids at 2 years, 51% still met criteria for DMDD 2 years later, and 4 years later, 36% met criteria. And there was a similar study published in 2016, which showed, looking at kids who met criteria for DMDD and looking at them 7 years later, about 30% still met criteria. So around a third of kids are going to continue to have problems with these symptoms over many years. Looking even longer than that, they looked at the couple different people, a couple different authors have looked at the Great Smoky Mountain cohort of children. That's a 15-year longitudinal study with over 1,000 kids that they've followed over many years. When they looked at it and kind of used retrofitted, all of these, the prior studies I was talking about for epidemiology, they're looking at retrofitted criteria. So taking cohorts of kids that have been studied and kind of applying the criteria as best as they can with the measures that they used. in those various studies. When they looked at the Great Smoky Mountain cohort, what we see is that 3.3% of the kids ages 9 to 19 met criteria for severe mood dysregulation. What they found was the stability of the diagnosis wasn't great. When they looked at kids, these kids were looked at in multiple different waves. I think there's been 5 different waves where they've assessed them. And that 9% of them had, of the 3.3% that had severe mood dysregulation, 9% still had the diagnosis 1 to 2 years later, and about 2% had the diagnosis over all 4 waves. So not everybody, not every kid who meets criteria for SMD or DMDD is probably going to have that throughout their life, but some will. Interestingly, what they found is when they looked at the kids who met criteria for severe mood dysregulation in the first wave, so kids starting at age 9 who had met criteria for SMD, looking at them at age 21, what they found was, or 18 to 21, what they found was they were more likely to have depression. An odds ratio of 7.2, they were 7.2 times more likely to have depression in that early adult age. Looking at age 25, they also found higher rates of depressive disorders and anxiety disorders. So really looking at these kids longitudinally, it does not look like these kids have bipolar disorder or psychosis or those type of chronic mental illnesses. They have more depression and anxiety. So what do we do? How do we treat these kids? So again, there's been very few studies completed at this point with using DMDD criteria from the start. So what we have to use is we look at studies that have used SMD, because that's been criteria that have been defined since 2003. So we look at studies with severe mood dysregulation as kind of a proxy for this. We look at studies of kids who have ADHD and ODD, because we know that up to 85% of the kids 75 to 85% of the kids who had SMD also had ADHD plus ODD, so those seem pretty highly comorbid. And then studies looking at aggression, studies looking at just aggression, or studies looking at ADHD plus aggression. So kind of have to look to those studies to try to figure out what do we do. So if we look at one of the most well-known studies of ADHD, we look at the MTA trials. Authors have gone back and looked at that trial, and looked at just some irritability measures that were tracked throughout the study. And what you see is over the 14 months of the study, kids in every single one of the treatment arms improved in terms of irritability. So kids in community care seeing their pediatrician getting stimulants in the community improved, kids with getting behavioral treatment improved, kids getting the intensive medication management where they were seen monthly and had their stimulant dose optimized, they improved, as well as the kids who had both the combination intensive medication management and the behavior treatment. So irritability responded to all of the different treatments in that study. So let's take a look just at psychosocial interventions first, because this was a combination. The MTA had a combination of psychosocial and medication treatments. So, an author named Waxmansky looked at, in 2008, did a study looking at kids. They did a study with kids who had ADHD. They were doing basically a study of a parenting intervention, and it was a 9-week summer program. It was parenting plus interventions for the kids. It was a larger group of kids. It was 106 kids. And they went back and looked at those kids and retrofitted the criteria for DMDD and found 33 of the kids in their cohort that they felt met criteria for DMDD. For SMD. So 33 of the kids met criteria for severe mood dysregulation. Kids were ages 5 to 12. They were in this 9-week summer treatment program. The kids got 3 different levels of stimulant dosing, different doses based on their weight. And they either got no behavioral interventions, a low-level behavioral intervention, or a high-level behavioral intervention. And you can see on the graphs there, looking at the kids who had just ADHD versus the kids who had ADHD plus severe mood dysregulation. What you see is basically a very parallel track in terms of treatment response, but not as robust of a response for the kids who had the mood dysregulation in addition to the ADHD symptoms. And basically what they found was that there was really they were effective interventions, but just not as robust for that particular treatment population. Waxmansky did another study building off of that. This was published in 2016. This was a psychosocial treatment intervention for there was 31 kids in the active treatment arm. So these were kids who had ADHD plus severe mood dysregulation. They had their stimulant dose optimized over several weeks, and then they either went to just usual care, or some of them went into a behavioral treatment that was aimed at the mood dysregulation piece. So 31 families went into the treatment arm, and 25% went to community care. The children in the studies were ages 7 to 12, and you can see that what they're calling the AIM was their behavioral intervention. It was a blend of CBT, parent training, and social skills groups. I've listed on the screen what the children did in the groups. So there was 11 105-minute sessions. The parents met in groups and had kind of a parallel curriculum to the children. So the children learned emotion recognition in self and others. They were trying to help them connect emotions and cognition. They helped them with problem solving and coping skills, and then tried to do some integration sessions. And unfortunately, what they found was that there was really no difference, having gotten that very nice parent training and CBT for the kids. There's really no difference than the kids who just had their stimulants optimized and went to community care. There was a couple of very small studies published recently looking at hostile interpretation bias. There have been some neurobiology studies showing that kids who have had disruptive mood dysregulation at any point, they tend to overinterpret more neutral stimuli, calling things angry when other people don't. So as you compare them to control, children who've not had any mental health diagnosis, if you show them pictures of people and you ask them, is this person happy or is this person angry? Children who have DMDD will label faces angry when kids who have not had a psychiatric disorder label them as happy or neutral. So they're sort of, kids who have DMDD are kind of over-reading negativity in others, so they think that somebody is furrowing their brow is angry at them or upset, and so they kind of have this more hostile or negative view of the world. So Stoddard has done a few studies looking at this. There are ways, there are treatment protocols where you can try to train people to have less of that negative bias when they're viewing people or and interacting with people. So he did a randomized controlled trial where kids either did the active training for hostile intentions or a sham sort of intervention, and they were able to show that they could teach the kids with DMDD to be less biased towards viewing people as being hostile, and that this was maintained 2 weeks later. He did another open label study with just 14 youth, because these are hard studies to do. Usually you're doing these in a lab, so it's a little harder to have large numbers of kids do this. So with 14 youth that had DMDD, they underwent 4-session bias training, and what we saw was that at 1 week and at 2 weeks, parents rated the kids as being less irritable. So they rated them as being slightly improved on a global improvement scale. And that is pretty much what we have as far as psychosocial interventions that have been done or conducted in kids either who have SMD or DMDD. So not a whole lot. There are a number of psychosocial or psychotherapy studies being conducted. Some of them sound very interesting, and I think we're going to be excited to see results from these. At Yale, they're doing a modified DBT protocol for kids ages 7 to 12, kind of looking at that emotion regulation piece, trying to teach them mindfulness. There's an interpersonal psychotherapy study being conducted for kids who meet criteria for severe mood dysregulation, so trying to help them with interpersonal skills and kind of role-playing and thinking about role. Another group is doing interpersonal psychotherapy for kids who have mood dysregulation and behavior dysregulation together, but not specific SMD or DMDD criteria. And then there's a group of people looking at cognitive behavioral treatment plus interpretation bias, like we were just talking about, for kids who have DMDD. So some interesting things to come, but I don't think we know anything really specific about DMDD at this point. I think at this point we would approach it as ADHD plus oppositional defiant disorder. We would be looking at parent training modules, as well as any kind of CBT focused on connecting emotion, thoughts, feelings, anything related to anger or hostile bias is kind of what we could recommend at this point. So what about medications? What do we know about medications and DMDD? Well, most of those studies are derived from kids who have comorbid conditions, including most frequently ADHD. So we'll start talking about ADHD and stimulants, since that's the most common recommendation for ADHD. So again, if we go back to the MTA study and we look at stimulants and stimulants response, if you look at kids that were labeled as kind of having uncomplicated ADHD, and you looked at kids who had ADHD plus mood dysregulation, what you see is that they improved in a parallel fashion, but that the children who had ADHD and mood dysregulation started where they were more impaired, and although they improved at the same rate, similar slope to the improvement, they ended still being more impaired than the uncomplicated ADHD group. So they improved, but they're still more impaired than other kids, and we know that even kids who have just ADHD with stimulants, although their behavior improves, they don't usually come back to the mean. So they still have more ADHD symptoms, more inattention, more hyperactivity, more impulse control problems than the average group in the community. That's for just uncomplicated ADHD, and then these kids with mood dysregulation are even more impaired than that. So in 2015, in the Canadian Journal of Psychiatry, Gorman et al., they published a large meta-analysis sort of looking at a wide variety of studies, looking at the effect size, looking at drugs, basically looking at medications for oppositional behavior, conduct problems, and aggression. And they looked at a wide variety of medications and tried to summarize where the literature is at this point. And so looking at what they pulled together, they looked at over 40 placebo-controlled trials for kids who were taking stimulants, where there were outcomes noted for oppositional behavior, conduct behavior, and aggression. They looked at a variety of studies from 1970 to 2001, looking at clinician, parent, and teacher ratings, and you can see those were all pretty high-quality studies and had effect sizes of 0.7 for clinicians and parents in terms of rating, and 1 for teacher ratings. So very good. If you recall, the effect size for the core ADHD symptoms, inattention, hyperactivity, impulse control, stimulants, the effect size for those core ADHD symptoms are usually between 0.9 and 1.2 in most studies. So you can see that the effect size for the disruptive behavior or aggression is lower than the core ADHD symptoms, but still pretty good. These are large effect sizes. If you look at studies where they looked from 2002 to 2013, looking at parent and teacher ratings of kids who had ADHD with or without ODD and conduct disorder, we saw a smaller effect size for parents, but still a large effect size for teachers in terms of aggression, oppositionality. So we know that stimulants, we've had a lot of literature over many years looking at stimulants, and we know they can reduce disruptive behavior and aggression. If you look at other medications for ADHD, if you look at atomoxetine, there was 15 trials, and what they saw for oppositional behavior was effect size of 0.3, so sort of a small to maybe moderate effect size. That's technically in the small range, but with high quality studies. If you look at guanfacine, there's some 2 trials that had moderate quality with an effect size for oppositional behavior of 0.4. And with clonidine, there was very poor quality studies. Really can't extrapolate much from that. So certainly, if we're looking at oppositional behaviors, obviously the numbers are larger for the number of kids that have been looked at with stimulants, but stimulants seem to be more effective than the non-stimulant medications for ADHD. So if we look at stimulants and what's newer, what studies have been done specifically looking not necessarily at aggression, but looking at irritability, looking at these DMDD, these outbursts and things, which kids with outbursts, they often are aggressive, but they don't have to necessarily be aggressive. They may just be upset and unable to move forward with their day, upset, destroying things, or just very distraught, creating problems at home, but it may or may not be specifically, it may include verbal or physical aggression, but it can just be the emotional component. The Journal of Child and Adolescent Psychopharmacology, I think it was the March issue in 2016, they had 10 studies that were published that were looking at kids with DMDD and trying to kind of summarize where we're at right now. One of the studies published there was looking at kids, 64 kids who have ADHD plus DMDD, and looking at just stimulant optimization, open label trial, 6 weeks, stimulant optimization, trying to look at what happened to the DMDD symptoms. And so what they saw in that was that ADHD symptoms improved and disruptive behavior symptoms improved on the Disruptive Behavior Disorder Symptom Rating Scale. But they also saw that negative mood increased or decreased. Negative mood decreased, the mood improved using the Children's Depression Rating Scale. And these children also had improved functioning over the 6 weeks, open label titration of stimulants, improved functioning, the overall functioning on the CGAS. They improved in terms of academic progress. They improved as far as self-esteem, family functioning improved, and relationships with parents, sibling, and peers all improved. The effect size for all those improvements was in the moderate range, 0.4. But you do see that across multiple domains, kids do make improvements, at least in that short run. Of course, we know that with open label trials, we tend to see more robust results than we do with randomized controlled trials. Another article published in that issue was by Blader. Blader looked at several studies. He had conducted 2 trials where kids had stimulant optimization and then went into parent treatment. Following that, they could go on to some other steps in treatment, but the 2 trials had basically the exact same lead-in with the stimulant optimization and the parent training. And so he combined the results of those 2 trials. So they had 156 kids ages 6 to 13 who had ADHD plus aggression. So not exactly SMD criteria or DMDD criteria, but ADHD and aggression. 79% were noted in the study to have angry outbursts, so that sounds like something similar to DMDD. 72% were easily frustrated. When they looked at all the criteria for DMDD, only 30% of these kids actually met full criteria. But nonetheless, they took a look at these kids, and they had stimulant optimization, and they went into a family-based treatment that's called COPE. It was coping. I forget exactly what it's called, what the acronym stands for. It was done in Pittsburgh, and so it was a family-based treatment, basically a parent training kind of module. And what they found was that at the end of the study, it was a 9-week parent training, I believe it was 9 weeks, 51% of the kids were qualified as being in remission for aggression based on the modified overt aggression scale. So half of the kids had aggression improve, and they looked at what measures they had that the parents were filling out in those studies for depressive symptoms and for irritability. And what they found was that as the aggression improved, so did irritability and so did depression. So depression scores got lower as the kids got less aggressive. So basically they showed that they tracked right along. If the child was rated somehow as being very high in irritability but low in depression, they didn't improve quite as much as the kids who had more clear depressive symptoms. So kids that were aggressive but clearly had low mood, low enjoyment, lower self-esteem, things like that, they actually, you could see that with stimulant treatment and with parent training, with family treatment, that their mood improved, their irritability reduced, and their aggression all improved together. So we sort of have known this for years as we treat kids, that when the stimulants are working, everybody seems to be happier, but you can see that in studies that these actually track along together. And that is about all that's what we have as far as stimulants in DMDD at this point. Really don't have a lot of new information beyond that. So what we know at this point is that kids who have ADHD plus a mood dysregulation, they're more impaired than kids who have just ADHD. We know that the stimulants worked. They work for aggression and irritability and negative mood, but they just don't work as well as we'd like because the kids end up more impaired than kids who have just ADHD. And we know that even in the MTA trial, that at the end, 44% of the kids who underwent parent training were still impaired by their aggression. So we need more treatment. We need another approach. There really have not been studies looking at kids on combination ADHD medicines. So there's not been studies looking at kids taking stimulants plus an alpha-2 agonist or a stimulant plus atomoxetine for aggression, irritability, or negative mood, and we really need those studies. So we'll have to see what we see in the future with that. So how about other medications? So certainly these kids get put on other medications. They get put on medications that are used to treat bipolar disorder, or they're used to treat aggression. These typically include lithium, anticonvulsants, or antipsychotics. So if we look back at that 2015 Canadian Journal of Psychiatry issue where they kind of looked at all the studies published so far for aggression and oppositional behaviors, you can see that there was pretty low quality evidence for studies with lithium, valproic acid, or carbamazepine. It's just a few trials and not great quality, so it was hard to extrapolate from that just for aggression and disruptive behavior. If you look at antipsychotics, there was better information there. Most of it is with Risperdal, and those get kind of subdivided into kids taking risperidone who have normal IQ versus kids taking risperidone who have a low IQ. And then there was some low-quality studies with quetiapine and haloperidol, which are hard to extrapolate from. But if we look at risperidone, what we see is that in the 4 trials with kids that have normal IQ, where they looked at disruptive behavior or aggression, decent effect size, around 0.6 for those, and it was good quality studies. If we look at the kids with low IQ, looking at conduct problems or aggression, 5 trials, about 400 kids, effect size of about 0.72. So a large effect, a little bit more moderate quality to the studies. So that's kind of looking at aggression. So what about studies for severe mood dysregulation or disruptive mood regulation disorder? So looking at lithium and severe mood dysregulation, there was one study. It's a 6-week double-blind randomized controlled trial. Small study, 25 kids. They were off medications for 2 full weeks and then placed on to lithium. Their target blood level was 0.8 to 1.2. They were looked at on the CGI and on the PANSS, so looking at positive and negative symptoms. And basically what you saw looking at their clinical global improvement was no difference from placebo. So really no real clear improvement. Although I would expect, I think a lot of us would expect, a lot of us feel like lithium can work for depressed mood, but really didn't seem to make a difference in this small study. Looking at risperidone, there was one small study, 8-week open label trial, 21 kids, average age was 10, looking at how kids did on the aberrant behavior checklist, the irritability subscale, looking at CGI. They also looked at a number of other symptoms. And what they saw was that by week 2, kids had significant decrease in their irritability subscale on risperidone. They were started at a 0.5 milligram at night, and they were increased to 1 milligram on day 4, and by the end of the study, the average dose was 1.28 milligrams. That gave a robust effect size, 1.8. But again, this is an open label trial. We know that open label trials are more often positive as compared to randomized double-blind placebo-controlled trials, so we really need to see in a controlled trial what do we see as far as these kids' mood. If we think about the TEAM study, the Treating Adolescent Mania study, we know that in that study, when they looked at kids who had bipolar disorder, when they looked at several agents, lithium and risperidone were in that study. We know that when they looked at the depressed scales, that risperidone actually performed pretty well for treating the depressed symptoms in those kids who had bipolar disorder. So we might expect that it would do well in kids who had a disruptive mood dysregulation disorder, but we just don't really have any double-blind placebo-controlled trials for that yet. In this study, kids did improve on depression rating scales. They did improve for ADHD, and kind of their overall functioning improved. So we will look for studies with this in the future and see what happens. That's really all that we have as far as monotherapy studies for SMD or DMDD at this point. So what about combining medications? Because certainly I think in practice, often these kids and families are in such distress. I think that in practice, a lot of us see that these kids are on one medication, they get some measure of improvement, maybe a 40-50% improvement, but the family's still struggling, and even with psychotherapy, we might end up putting a second medication in place to try to target some other symptoms. So what about medication combinations? What do we know that's been studied? So most of these look at ADHD and maximizing the ADHD treatment first, and then adding something else on, because the vast majority of these kids do have comorbid ADHD. So this is a study from Blader, published in 2009. This was one of those studies I was talking about earlier, where they had the same run-in, the same study design, where the kids were optimized on stimulant medications and given parent training, and then if they still had symptoms, they could get other medications. So in this study, at the kids, if they still had significant aggression at week 3 of the study, they could go, as at week 9, they could go into this additional add-on with divalproic acid extended release. And you can see there kind of how what the study results were. There was 14 kids who got the divalproax, and I think there was 15 kids that got placebo. So there was separation towards the end. There was technically 8 of the 14 kids on divalproic met remission criteria on the modified overt aggression scale. So versus 15% of the kids, only 2 out of the 13 on placebo. I think a few of them dropped out by the end for placebo. And so it was only 2 out of 13 that met remission criteria. So similarly, this is not DMDD or SMD, but looking at aggression, children with ADHD who were also aggressive, who were treated with stimulants and parent training, and then could get either placebo or risperidone. You might know this as the TOSCA trial. So in this study, kids had stimulant optimization in the first 3 weeks. If they still had aggression, they then got randomized to placebo or risperidone. They were all along with that, they were getting parent training. So the parent training was happening as they were taking both of these medications. And what you see is that the children in the augmented group, which is what they call the risperidone group, they had better outcomes in terms of lower rating scales on the disruptive behavior rating scales that they were using. Effect size was 0.5 from the addition of the risperidone. So a moderate improvement using risperidone with parent training and stimulant medication. And that's pretty much what we have as far as the literature in terms of medication combinations. There are 3 studies underway looking at combination studies. So Liebenluft is looking at kids who have severe mood dysregulation, getting stabilized on a stimulant over a 5-week period of time, and then they're being randomized to citalopram or placebo for 8 weeks. McGuff is looking at kids getting stabilized on lisdexamfetamine over 4 weeks and being randomized to fluoxetine or placebo for 8 weeks. So a couple studies looking at SSRIs. If we think these kids grow up to have depression and anxiety, trying at a young age to put them on SSRIs to see, can we help that mood? Can we help that negativity? Can we help their emotional reactivity in some way? So 2 studies looking at that. And then another study that's looking at a double-blind for 8 weeks using either MPH or risperidone, kind of comparing the 2. So trying to help figure out which of these should we start with, which of these give us greater improvement for kids who have DMD and ADHD. So what does that tell us as far as Florida treatment guidelines in terms of best practices? So the guidelines that are put together show these different levels of treatment. So level 0 is a comprehensive evaluation. So all kids when they come in, all kids should get a comprehensive assessment. When we're thinking about DMDD, we want to assess for conditions where irritability is prominent, including all the things we've been talking about: ADHD, ODD, bipolar disorder, depression, anxiety, PTSD, autism, psychosis, drugs and alcohol. We'd obviously want to get a family history, get collateral information. We'd want to get medical history of medications, even medications for other conditions that could be contributing. Do they have asthma or allergy medications they're taking that might impact mood or something like that? and assess their psychosocial stressors. The guidelines don't explicitly say this, but the implication is that if they have a comorbid condition, well, obviously if they have something other than DMDD, you should treat that. If they have a comorbid condition to DMDD, you start with treating the comorbid condition because we have much better idea of how to treat those comorbid conditions than we do the DMDD itself. So you would start with that kind of treatment. While you're doing that, if you know that you're thinking about DMDD, or if you know the kid has DMDD, or there's just a lot of irritability, you may want to track irritability using a rating scale, and you may want to track aggression and outbursts. This can be very helpful because, even with treatment, these kids are often impaired, and so it may help you to have an idea of how the aggression is shifting or how the irritability is shifting, and it may help the parents also, remember that there has been some improvement, and try to be realistic about your expectations. So there are, on the MedicaidMentalHealth.org website, there are several of these several of the rating scales that are in the public domain that are available. For irritability, there's the Affective Reactivity Index, and for aggression, there's an Overt Aggression Scale. So just to show you a quick screenshot, the Affect Reactivity Index, very short, simple questions. There's a parent version or a self-report version for kids ages 11 to 17. So are you easily annoyed by others, lose your temper, stay angry for a long time, angry most of the time, get angry frequently, lose temper easily, or feeling irritable? So pretty simple, and you can track that over time. Modified Overt Aggression Scale is very helpful, I think, for parents to be filling out. So you rate it in the past week, and you can separate out verbal aggression, aggression against property, aggression towards themselves, aggression towards others. And to try to figure out where is the biggest problem and where have you had the biggest impact with any kind of treatment. So level 1, obviously, you would be assessing and looking at rating scales, address any psychosocial stressors, looking at symptom severity. If the aggression is more verbal aggression and the irritability is there, you may start with psychosocial interventions. Could be as simple as targeted case management, helping them deal with psychosocial stressors, help to make sure they've got school interventions in place if needed, maybe parent training, cognitive behavioral therapy for the child, things like that. If you've got moderate to severe symptoms, you've got significant aggression against others, you've got a lot of symptoms where you think it's going to be hard to keep the kid in the home or keep the situation safe, like a child is being expelled from school or has had multiple hospitalizations or a DCF is involved, you may want to think about level 2 interventions. With level 2, we start with always reassessing the diagnosis, make sure we know what we're treating, make sure we haven't missed something, and then you may want to consider some targeted treatment of aggression. Assuming you've already optimized ADHD treatment, thinking about adding an atypical antipsychotic, thinking about adding a mood stabilizer, an alpha-2 agonist, or an antidepressant in conjunction with your psychosocial interventions. So you don't want to just use medication alone. We really want to use multiple modalities because there are certainly, these kids accumulate side effects with all these medications, not the least of which can be weight gain and other things that impact their health overall on these various medications. So basically, to summarize, we know that DMDD rarely occurs alone. It's often co-occurring with ADHD and ODD. We need a careful diagnostic assessment. You really want to note the frequency, intensity, and duration of the outbursts. And you may want to think about using rating scales if you have not already been using those to track irritability and to track aggression or aggressive outbursts. You want to treat any comorbid disorder, especially ADHD. If you have ADHD, you want to maximize stimulant response because that's what almost all the trials are doing first. So that means seeing the kid frequently, using rating scales for the ADHD, maximizing response. And then start treatment for DMDD with psychosocial interventions, parent management training, any groups or cognitive behavioral interventions for kids, anything to help target that emotion regulation or maybe talking about hostile bias interpretation. And then you could consider adjunctive medication with risperidone or an SSRI. So that's pretty much what we know at this point, so I'd be happy to entertain any questions if people have them. So yeah, I know I get a lot of questions about how to, what to do, how to treat things, and I don't think we really have any idea how to treat these kids. We know that these kids are very impaired at home and at school. We know, I think most of us feel like these are kids that are familiar. We've had them in our practice forever. We probably in the past have called them DMDD, called them ADHD and ODD, and tried to work with that. So I think I just saw a question. So how do you manage the hostile patient whose parents want to involuntarily commit their child for hostile outbursts? I don't know. I think that, we don't really know. Certainly hospitalizations, the way hospitalizations are conducted these days, hospitalizations tend to be very short. That's unlikely to be very effective unless, sometimes these kids and families may need a brief hospitalization just so everybody can cool down and get through a very difficult outburst. It may be that in the hospital, very briefly with crisis intervention, people could think about, what to do the next time that there's a situation where somebody is upset. But really, these are chronic conditions, and a chronic condition isn't going to be well treated in a short-term psychiatric hospital. I think you could look at residential treatments, if there are longer-term residential treatments where kids might be able to go to really get skills. If the kid has a very clear skill deficit, if you've got programs nearby that really help the kid, if the kid's at a point in their development where they could try to work on cognitive behavioral principles or DBT kind of principles and develop some self-awareness and develop some skills. But really, I think talking to parents and families about, there isn't necessarily a quick fix for this. It's likely to be long-term. They need to have realistic expectations about how the kid is going to do. They need to try to have consistency. They need to try to set their home up to be, so everybody can try to be successful and have less frustrations on a day-to-day basis. And then I think just talking to them about what we do know and going from there. Let's see, are SSRIs currently being used as adjunctive treatment, or is this class only being studied? I think the studies right now are going to be as adjunctive treatment. I don't know if I didn't see that anybody currently has studies registered that are just with an SSRI. I think certainly, you might be able to get away with just an SSRI. It seems like a lot of these kids, since so many of them have comorbid ADHD, most of them are already on ADHD medication and then have an SSRI. So I'll be interested to see what those studies show. I know in my clinical practice, what I see is that kids who have ADHD, and you give them an SSRI, sometimes if they're pre-pubertal children, sometimes they become very disinhibited. Their hyperactivity gets worse, their impulse control gets worse. And so it's sometimes hard to use those two medications together. I find that I can really only use very small doses of an SSRI most of the time, and it's not very effective to use high doses of SSRIs. So I guess we'll see. What about treatments for adults with DMDD? Same thing. We don't have any good treatments that have been outlined for that. Basically, for adults, we would think that they are adults who have persistent depressive disorder or generalized anxiety disorder along with poor coping skills. So I think for an adult, you would treat them with any kind of treatment that helps with interpersonal skills and emotion regulation skills, coping skills. So, that falls short. Adult who has DMDD might also meet criteria for a personality disorder of some sort, or at least a lot of personality traits. So I think you'd be looking at any kind of therapy that would help them develop metacognition skills, mentalization, coping skills, any of that. What is the data looking like as far as the likelihood of DMDD early on, which is correlated with bipolar disorder later? There really is no overlap that we're seeing between, I shouldn't say none, but if you look at the kids, there's been a number of studies, looking at kids who have this question of bipolar disorder. So if you look at parents who have bipolar disorder and you look at their kids do not meet criteria for DMDD. They do not have chronically irritable, explosive children. What they have is children who look fine in the pre-pubertal years, who go through puberty, who then develop depression, who later develop manic symptoms. When they did the studies looking at these kids who had kind of bipolar NOS, and you looked at their parents did not have bipolar disorder. Their parents had substance abuse and depression and anxiety. So really, it looked like they were very different in terms of if you looked at the parents who had bipolar disorder and the parents who did not have bipolar disorder and their kids, they literally looked like different cohorts. So I don't think we're going to see a lot of these kids who have DMDD that turn out to have bipolar disorder, because most of the kids who have true bipolar disorder, they don't have a lot of aggression and irritability and outbursts in the pre-pubertal period. They may have some dysphoria, some anxiety, but it's really after puberty that you're seeing, which is why onset for DMDD needs to be before age 10. It's really after puberty that you're seeing manic symptoms and things like that. It's a good question. Let's see. Is there any research support explaining how the family system and family organization affects the development of DMDD. I don't know that I've seen that literature. There's a lot of literature these days out on irritability. A lot of it looking at how heritable that is. It is quite heritable. And so it's one of these things where it's complicated. You have a lot of rigid, irritable parents who have rigid, irritable kids. And so then that is both a genetic liability as well as, kind of modeling, not necessarily a very flexible environment. Parents who have a hard time picking their battles, that's the whole treating your explosive child, is trying to teach the parent how to prioritize what's important to get the kid to do and what's not important to get the kid to do. So certainly, part of the parent training is helping the parents think about how much have they set up routines in their house? How well are they setting up their weekly routine? How much can they help their kid? How can they anticipate what's going to upset their kid, help their kid, give their kid warnings, and model good skills? So there's a lot of things out there these days about teaching parents to try to stay calm when their kid is upset. So that's a lot of these mindfulness parenting interventions. But I haven't seen anything that specifically connects those or outlines how those are related. But I think the family variables, certainly we know for depression that family dysfunction or a lot of high family affect affects the development of depression. It's probably the same for these kids. Let's see. Does autism spectrum diagnosis trump as ODD does? Not necessarily in the DSM-5. I mean, the DSM-5, it says if you have oppositional defiant disorder and DMDD, you should just have DMDD as your diagnosis. It's probably doesn't add a whole lot to say they have ODD plus DMDD, since almost every kid, most of the databases people have looked at, almost all kids who have DMDD also have ODD. If you look at the kids who have ODD, maybe 50 to 60% of them also have DMDD. So there are some kids who have oppositional defiant disorder who don't have persistent irritability, but when you look at DMDD, it's almost pointless to say that they have oppositional defiant disorder because they almost all do. I've not seen the same thing for autism. Plenty of kids who have autism spectrum do not have oppositional defiant behavior. They don't have irritability in the same way necessarily, so I've not seen that. Should mitochondrial status be considered prior to starting Depakote on low-functioning children? I have not seen anything about that. My understanding is that mitochondrial status is pretty difficult to assess. I'm not sure exactly what people are referring to, so I have not seen anything about that. What do we do with young children who have autism, who develop aggression and are also hurting themselves? That's a kind of a whole different talk. Really not a lot. Unfortunately, we don't know a lot about what to do for self-injurious behavior for kids who have autism. Really nothing has been found to be that useful as far as pharmacologic strategies. So I think working with occupational therapists or treatment teams on all sorts of assisted devices, whether it's helmets or mittens or different ways to try to help keep kids from hurting themselves. Has there been any studies done with a change in diet? I have not seen studies with diet related to mood. I don't know if anybody else has. Certainly there have been studies looking at diet in terms of ADHD, looking at reducing food colorings and food additives and dyes. Certainly there was the old, I think it's called Feingold diet. But really I have not seen, and there's obviously been some studies looking at casein-free, gluten-free, those kind of diets with autism. Those studies are kind of equivocal. You really don't see that there's any robust response for autism with diet, and I don't think I've seen any studies with mood disorders in diet. And you want to conceptualize disruptive mood dysregulation disorder as kids who have ADHD, who have trouble regulating their mood, who are going to have persistent low mood, perhaps anxiety, and I just really haven't seen any mood disorder studies with diet. So hopefully that's answered some of your questions. I think the answer is we don't really know anything different. We're calling these kids something different. We've had these kids in our practices forever. We're giving them a different label. We hope that down the road, studying things like irritability will help us figure out what to do differently, but I don't think right now anybody knows exactly what to do differently. But labeling it differently, trying to think about it in different ways other than just ADHD is trying to help people study some different kind of treatment interventions. I'm going to be excited to see what those psychosocial interventions like interpersonal skills training and DBT and hostile bias training, kind of what those show. But I think we've got another 5 to 10 years to really, I think at least 5 years to see some of these studies getting published. Some of them are wrapping up and doing data analysis, so hopefully we'll have something soon. So I guess unless there's any other questions, I appreciate everybody's time and attention today.